Good evening and welcome, everyone. I'm Michelle Heritage, the Executive Director of the American Brain Foundation, and I am pleased to introduce to you tonight's host, Dr. Charles Flippen. Dr. Flippen is the Richard D. and Ruth P. Walter Professor of Neurology, faculty member of UCLA's Goldberg Migraine Program at the Ronald Reagan UCLA Medical Center, Vice Chair for Education in the Department of Neurology, and Associate Dean of the Center for Continuous Professional Development at the David Geffen School of Medicine at UCLA. Dr. Flippen is a diplomat of adult neurology, of the American Board of Psychiatry Neurology, and of headache medicine of the United Council of Neurological Subspecialties. He's a member of the American Headache Society, International Headache Society, Fellow of the American Neurological Association, and Fellow of the American Academy of Neurology, where he serves as the treasurer. In addition to his AAN activities, Dr. Flippen represents the ABPN on the Neurology Residency Review Committee of the Accreditation Council of Graduate Medical Education and serves on several intramural committees in the DGSOM. Dr. Flippen is also active within his community in Los Angeles through his service as a board member of 100 Black Men of Los Angeles, member of the Sigma Pi Phi fraternity, Delta Chi Boule, and member of Alpha Phi Alpha fraternity. Dr. Flippen, welcome, and I turn it over to you.
Hey, thank you, Ms. Heritage. Welcome, everyone, and thank you for joining us tonight. Our topic tonight, we will learn about neurological healthcare disparities, a complex issue involving systemic barriers affecting access to care and quality of care for individuals with neurological conditions, particularly for people from historically marginalized racial and ethnic groups, individuals from lower socioeconomic backgrounds, people with disabilities, and those with limited education. Addressing these disparities is crucial for ensuring equitable health care for all. Webinar events like this one tonight are opportunities to connect you with experts in various topics of interest around the brain and neurological care. I invite you to put your questions in the chat at any time, and after the presentation, we will try to address as many questions as we can in a Q&A session. The American Brain Foundation funds research across the entire spectrum of the brain and nervous system, knowing that brain diseases, disorders, and injuries are all interconnected. The American Brain Foundation is currently funding 2 researchers studying neurodisparities. Their research areas include end-of-life disparities in Parkinson's disease and social and psychological determinants contributing to disparities in stroke. The ABF began awarding a neurodisparities grant in 2022. This year's awardee, whose funding begins in June, will be studying multiple sclerosis in Zambia. The ABF cannot exist without support from donors. If you are so moved, please make a donation so that we can continue funding critical research and continue to host free webinars like tonight's event. You can give at americanbrainfoundation.org/donate or scan the QR code on your screen. Now let's move into our topic of conversation, neurological healthcare disparities, with our guest, Dr. Bruce Ovbiagele, Professor of Neurology and Associate Dean at the University of California, San Francisco, Chief of Staff at the San Francisco Veterans Affairs Healthcare System, and recipient of the American Brain Foundation's 2024 Scientific Breakthrough Award, which will be given next month at the annual Commitment to Cures Gala. On a personal note, I've known Dr. Ovbiagele, Bruce, for over 20 years as he started his career at UCLA. I can tell you he is equally as outstanding a neurologist and educator as he is scientist. It has been a personal treat watching the progress of his career. I consider myself fortunate to have him as a friend and colleague. So thank you, Bruce, for joining us tonight. And let's get started. Your work involves translating evidence-based interventions into clinical practice and community settings to improve stroke outcomes for underserved and vulnerable populations. Can you give me some examples of what this has looked like?
Yeah, no, thank you, Charles, and thank you everyone who has kindly tuned into this discussion. I have to give my profound gratitude to the American Brain Foundation, first of all, for this forum, and also for this immense recognition. Certainly, it's not my doing alone. I stand on the shoulders of giants, and I see this recognition as one which recognizes the many people who've mentored me, sponsored me, guided me, collaborated with me. And so this is for them, and for that, we are all truly grateful. Having said that, again, it's also an immense pleasure to have Dr. Flippen kindly moderate this particular session. As he mentioned, known each other for 2 decades and inspired each other over the years. So thank you, Charles, for kindly doing this. To the wonderful question that you asked, I think when I think of the work I've been privileged to do, the one unifying theme throughout all of this is a desire to extend the reach and the impact of science through science. And that might seem a little bit counterintuitive, but my work is really focusing on making sure that many vulnerable and underserved populations actually get the benefit of science, but doing so in a rigorous way. And so, for instance, some of the programs we've been involved in, and Charles, you might remember this, when I first started at UCLA, we had the Stroke Protect program. And that program was a clinical pathway-based initiative really aimed at trying to improve the utilization of evidence-based therapies after people have left the hospital following a stroke. And what we did with the Protect program was showing that the program itself, which was really driven by a number of different pathways, actually helped to maintain the utilization of these evidence-based therapies 3 months and even 1 year after people left the hospital. And when we compared it to traditional care after people left the hospital, it was actually associated with a reduction in the number of vascular events that occurred 1 year later. In fact, many of the protocols that we developed in the Protect program were later utilized in the AHA, American Heart Association, Get With The Guidelines program, which has transformed stroke inpatient care nationally and even internationally. So it was a privilege to be at the foundation of developing those type of protocols. But that led to a curiosity in me. Both myself and Dr. Flippen worked at the Ovbiagele UCLA hospital, which is a safety net hospital in LA that caters largely to a mostly immigrant and Latinx population. And working there and working at UCLA itself in Westwood, it was very striking to me in terms of the differences in both care processes and outcomes. And that led to a lot of the work I subsequently did in trying to develop evidence-based therapies to improve the utilization of stroke therapies in underserved populations, including at Ovbiagele UCLA. So for instance, one of many things that we have done was to take a look at the prevalence of stroke in middle-aged women across the country. And what we found was that there was a tripling of the stroke prevalence rate in women aged 35 to 54 between the years 1988 and 2004. This had not been reported before. And we saw that when you compared women who were between the ages of 45 to 54 compared to their similarly aged male counterparts, we saw that there was a significant increase in stroke rates at midlife by sex. We associated it with a surge in obesity and diabetes rates in women in particular. And our articles, a series of articles that we had published with Dr. Taufigi, brought attention to the need for more vigorous lifestyle modification approaches in women. And when we did a follow-up analysis a decade later, we found that that difference, that bulge, so to speak, had actually disappeared. We've also looked at the rates of stroke in South Carolina amongst African Americans, looking at their care, looking at their outcomes. We've looked at rates of vascular dementia, also in South Carolina as well. But a lot of the work we've done over the last decade has looked at global health equity. And I was gratified to hear that the ABF is sponsoring a study in Zambia of multiple sclerosis. But we focused in West Africa, and we conducted the largest epidemiological investigation of stroke in sub-Saharan Africa, 4,000 cases and 4,000 controls. We uniquely characterized the phenomics and the genetic variants associated with stroke amongst indigenous Africans. And we also did the first genome-wide association study of indigenous Africans ever, in which we identified emerging roles of regulatory RNA, introgenic non-coding DNA, and several other unique genetic variants associated with ischemic stroke in indigenous Africans. We conducted the very first implementation trial of stroke in sub-Saharan Africa, which showed that text messaging and a modest financial incentive actually improved post-stroke outcomes in Nigerians who were studied in that particular analysis. And then finally, we are currently doing two separate studies. One is of a polypill in Ghana, and the other is of a nurse-supervised phone-based intervention also taking place in Ghana, looking at control of blood pressure after stroke. So these are many of the things that we're doing. We also have another study in South Carolina, but the emphasis of my work has really been trying to bridge these gaps, both locally and globally, when it comes to neurological inequities.
That's all, it's all very exciting work. And I think it's very interesting how it started at a very local level in northern Los Angeles and then has now gone global. It demonstrates, I think, that how really the world is really small, and that problems in one place, you can use similar techniques and start to address them in others. Really great work. What strategies do you recommend for healthcare providers and researchers to better understand and address the unique health needs of underserved populations?
Yeah, no, thank you, Charles. That's a big question. And one of the things I should first of all call out, since this forum is really speaking to the issue of addressing healthcare inequities and disparities for our neurological patients, is that many of the disparities that we see, we've known for a very long time. For instance, when it comes to stroke, both in terms of racial disparities and regional disparities, we've known about them for 50 years. But the disparities have barely budged. This has not been for want of studying them. And so one of the questions, of course, in 2024, one has to ask oneself is, what could we be doing differently? Not so much in frequently chronicling these disparities, but actually narrowing them or actually making them disappear. And so increasingly, we are focused on the issues of the social determinants of health. And of course, for those of you who might not be aware, these are those conditions in which all of us live, learn, and work and play and even worship in, but which have a huge impact on our health risks and our outcomes. And increasingly, we are seeing that those social determinants play a very large role in impacting and influencing the disparities we later see in many of the patients that we have the privilege of taking care of. And so what we are seeing now is many people are focusing more upstream, so to speak, rather than for me as a stroke neurologist. I see the stroke patient, they've experienced a stroke. I see that it disproportionately affects several minority racial and ethnic groups, but thinking a little bit more upstream as to how we can think about the milieu in which those patients actually find themselves in and try to address that. And so when we think about the social determinants of health, we think about things that have to do with access to healthcare facilities, whether they're hindered by lack of transportation, geographical distance, employment issues, incarceration, political factors. We also think about the issues of healthcare knowledge as well, healthcare awareness. How are those impacted by language barriers? For instance, Spanish. Charles and I saw a lot of that at UCLA. How are they impacted by cultural differences and our ability as providers to be able to be culturally sensitive to the populations that we serve? So to answer the question, I think part of the strategy to try and bend the neurological disparities curve, so to speak, has to start with providers and researchers better understanding the populations that they serve, better understanding how the social determinants of brain health affect the populations that they serve, incorporating health equity methods and approaches into the curricula of our trainees, whether it's at the medical student level, the resident level, whether it's at the fellow level, even when it comes to long-standing, continuing education. I think those are avenues for us to impart knowledge about approaches to try and bend the disparities curve. I think more has to be done in terms of research. Again, I think a lot of the emphasis has been on observing as opposed to really trying to intervene. But I do think that the pendulum is changing and people are beginning to recognize that we've observed enough. Not that we will ever stop observing, but really more of the emphasis needs to be on trying to bridge those disparities. You might also ask yourself, well, how does one do this in a way that's cohesive? One of the things that I've observed over the years has been this area is not as well known as it could be. This area is a little bit more controversial than it needs to be. And that's because when you speak about the issue of social determinants, we as providers, we're not as accustomed to thinking that way or thinking we can have an influence on those areas. And so a lot can be done in terms of us being more humble and more open to learning about how we can do things differently in this domain. Part of the issue of trying to move the needle is also to get more people who are from these disproportionately affected groups to be providers, to be researchers, to be educators. Because many of them have a passion, not unlike me, not unlike Dr. Flippen, to try and move the needle in many of these populations. So I think it's very important for us to also train such groups. But one of the things that I think is important is to try and make this a dedicated academic discipline. See, when I speak to people generally and I talk about health equity or health disparities, many times people don't know the difference between the two. When I talk about diversity, people ask me about what's the difference between diversity and equity and social justice and belonging. And then there are all kinds of acronyms and everything. And so for me, as I continue to learn myself about what might move the needle in this space, I think it will be welcome for us to have a dedicated academic discipline for achieving optimal brain health, which is a representation of an integration of different entities: health equity, diversity and inclusion, neurology, neuroscience. And what I'm calling that tentatively and announcing it for the first time is equity neuroscience. How I would define that would be the study of the molecular mechanisms through which the brain mediates major differences in health outcomes, as well as the distinctive barriers and facilitators to optimal functioning of the nervous system for everyone, every time, and everywhere. And the remit of such a discipline, equity neuroscience, it would include basic science all the way through population health. It will include both local and global scope. It would also involve exemplary topics, say, for instance, the neurobiology of bias, the neurobiology of compassion, social epigenomics, implementation science, the science of diverse subject enrollment and retention, workforce research. But it'll be a way for us all to come together and speak the same language. Because rather than people thinking about it more as being socio-political, seeing it as a serious academic discipline that requires the kind of attention, the kind of funding that I think will help us to actually bend the curve eventually.
Well, I think we are gifted now with being the first to hear the term equity neuroscience, and everyone mark your calendars. You heard it here first. But I think you touched on really several important themes there. The concept of social determinants of health. Yes, it is part of what we do. And if you really look at the history of medicine, there were luminaries in our past who recognized that what was then termed social medicine is actually important of preventing disease, because by the time they see us, a patient sees us, the horse is out of the barn, so to speak. But you touched on something else about the next generations of neuroscientists and clinicians. Can you speak to your mentorship for early career researchers from underrepresented groups in medicine?
No, thanks, Charles. Again, while there's a lot of room for improvement, I think it's fair to say, and I hope you'll agree with me, that things are certainly better 20 years later now than when they were when you and I were initially starting out. So, and I think that has been because of a recognition by many that this is important. I've been privileged to mentor so many people, and I don't think there's anybody who I've mentored who hasn't also mentored me, whether they knew it or not. And so that's been a privilege. But I've also been fortunate to have conceived of and led several mentoring programs, one of which is the Transcends program, which is funded by the National Institute for Neurological Disorders and Stroke, and also funded by the American Academy of Neurology. And we are now in our 7th cohort of scholars. It matriculates people who are underrepresented in neurology, and this is by not just by race and ethnicity, but also by disability status or by socioeconomic background as well. And so to date, we have matriculated over 30 scholars into the program. As part of the program, our scholars are exposed to mentoring, they're exposed to obtaining a Master of Science in Clinical Research degree, they're exposed to the enrichment of activities at the American Academy of Neurology, and many of them are already doing and going on to do fantastic things and becoming leaders in neurology. And what we hope is that they will pay it forward and they will continue to mentor others. Already we have some of them who are now mentoring some of the newer cohorts in Transcend. So that has been a gratifying experience, which we hope to continue. In Africa, we have a similar program, again funded by the National Institutes of Neurological Disorders and Stroke, called Talents. And in that particular program, again, we're recruiting very promising individuals from various parts of sub-Saharan Africa into a program where they get an online research credential. They are mentored by phenomenal people around the world. But the difference between this particular program and Transcends is that this program aims to have as its successor a program that is developed in Africa and funded by Africans and will begin to confer the first Masters of Neurological Research degree for Africans. And so we are now going into our 3rd cohort of trainees. These trainees, the folks we're training, will become the faculty that will administer this credential through the University of Ibadan in Nigeria. It will be an online credential open to Africans who are interested in neuroscience research. And so that's one of the other programs that we're involved in as well. I should also talk a little bit about our Heads Up, which is a partnership, again, between the NIH and the American Heart Association. It's an annual symposium. But as part of the symposium, which focuses on health equity as it pertains to stroke, we have travel scholarships for very promising early career folks to come to the symposium, which takes place a day before the International Stroke Conference each year, and to be exposed to an enrichment of academic activities and also to present their own work. So they hear from superstar researchers, they present their work at a poster session, and they get mentored and create a network. Because part of this whole, part of what I've learned from all of this is that mentorship, of course, is extremely important, but creating a network of peers is also very important to encourage and inspire each other. Just like you and I, Charles, encouraged and inspired each other as well. We did it on a small level, but what we're hoping to do is replicate it on a much broader level, and we do that as part of Heads Up as well. And most recently, I'm very grateful to announce that we are soon to be funded with a T32 grant from the NIH. It's called Enlighten, and it will be a fellowship, which will be the first global neurological equity T32 that we're aware of. But really, again, it's another aspect that we think is important in the career continuum, which will allow scholars who are trained in local equity to also partner with scholars who are trained in global health equity. Because as you mentioned, Charles, there are really no borders, and there are opportunities for both avenues to inform each other. And we think that with Enlighten, we can develop this cohort of individuals who will learn together, grow together, advance together, and move the field forward together as well.
That really sounds exciting. It'll be interesting to see how Enlighten evolves over time. What can organizations like the American Brain Foundation do to further support and amplify the work of researchers and clinicians in addressing neurological health disparities?
So the American Brain Foundation, of course, is doing a fantastic job already. I mean, we've heard about these neuro disparities grants for early career folks. So more of that will be great. The American Brain Foundation also has a health disparities subcommittee, which I'm privileged to be a part of as well. And so I think that's great. I would love to see at some point there to be an opportunity for the American Brain Foundation to fund center grants that would allow researchers of different disciplines, all with an interest in health equity, to work together and try to address problems from various angles that pertain to neuro disparities, so to speak. I'd love to see more symposium sponsored under the auspices of the ABF that allow, again, people from around the world to come together and brainstorm about ways to try and bridge neurological inequities and disparities. Those would be angles that I think the ABF should take, but already I see that the ABF is working very, very well in that direction.
Now, you mentioned earlier about that attacking disparities, it's a big tent because of the social determinants of health. Any thoughts on how to bring in other, or if you local geography of UCLA, we would call it North Campus, and that is those people who are in say sociology, psychology, policy, public policy, bringing those people into this concept of the center for study that ABF could help fund. How do you bridge those the gap between those fields?
No, and I know a point so well taken, Charles. I think you bridge those gaps by creating mechanisms, funding mechanisms that incentivize researchers of various disciplines to come together. So when you put out that call should hopefully foster an ability for individuals of various disciplines, especially these disciplines that have to do more with the social aspects of medicine, to come together. I mean, lawyers as well. I mean, I think that's an important part of this as well. But I think the ABF potentially putting out such calls, the ABF potentially partnering with the NIH, the ABF potentially partnering with foundations to put out such calls, because normally, as you said, these are strange bedfellows, and I think it's only if there is an avenue in which funding is available and the funding mandates that people work together, that's when you tend to see those type of things happen. And so I think the ABF, with its expertise, its experience, its remit, would be well positioned to foster such collaborations which might not occur naturally.
And I'm going to give you a chance to sort of be king for the day. What do you think would be the most critical steps to be taken at a policy or institutional level to achieve health equity in neurological care?
Yeah, so at an institutional level, as I mentioned, I think, so maybe I should start off with the department, right? So one of the reasons why I'm very enamored of this concept of having a dedicated academic discipline that has a clear definition and has a remit that is just focused on neurology is because I think we are leaving a lot of people out who could be part of the numbers who would help us to move the needle in this area. And so within an institution, I think within a department, having a vice chair for equity neuroscience, so to speak, would be, many departments have vice chairs for DEI. Many times my colleagues will ask me, what's health equity? Does that mean equity in health outcomes, or does that mean equity in the workforce? And so I think having a representation at leadership around a well-defined academic discipline would be important. I think having fellowships, training fellowships, equity neuroscience training fellowship, again, and not necessarily just allowing, making it just for neurologists, but having other disciplines that are pertinent to moving the needle for neuroscience disparities and inequities would be important. I had mentioned the issue of curricula would be important. I think having clinics, having equity neuroscience clinics in which you have health services researchers working with neurologists would also be, I think, a step in the right direction. We all know that we have our work cut out for us when it comes to trying to recruit more underrepresented folks into clinical trials. And so I think this framework, to me, again, speaking as if I were king, having this framework, I think, is very, very important. And that would be the one thing I would do, whether it is going from a department to an institutional level, whether it's going all the way to NIH, but having some kind of well-defined, well-recognized tent that people can work with and know what it is they're talking about and know what direction they're going in, I think is extremely important. Because part of what I think the challenge is, and I mentioned this already, is I think that in some situations, people minimize the issue because they feel, well, we've done the science, no problem. I think in other situations, people are very well-intentioned, but feel that maybe perhaps based on their own background, they are not entitled to dabble in this space or to get into this space, which should not be the case at all. I think that when people hear about health equity, they think it's just for certain groups. One of the things that's not recognized as much is that even in neurology, there are certain disparities that fly against or go against the typical disparities that we see. So for instance, I'm aware that with brain cancer, actually you have higher rates in non-Hispanic whites than you do when you compare it to non-Hispanic Blacks and Latinx populations. That's not a disparity that is frequently mentioned. Why is that? How is that being studied? There are things like that. So I still think this issue of better definition, a little bit more of firmness to the academic nature of things, I think would be important, because I hear from colleagues all the time, oh, social determinants of health. Bruce, how do you expect me to even know what to do with that? That's for politicians. That's for, and I think that to change that, I think it would be important for us to educate people, but also to make clear that we have a role, so to speak, in all of this. The other thing I also mention is this, and this may be a little bit controversial. I know that Charles, you and I have spoken about this. I think it's imperative that we diversify the workforce. That's imperative. But I also think it's imperative that our North Star always be equitable brain health. And that when we are diversifying the workforce, when we are increasing a sense of belonging, the North Star is with a goal to bridge inequities and disparities. I think that if we don't make that link, we lose certain people. And I think it's extremely important that that link be made in order for us to be able to move the needle. There are many of us that feel that diversity is important for a variety of reasons, including historically, But I think to bring everybody on board and to make sure that we are prioritizing the issue of disparities, I think that making that link is extremely important. So that's what I would do. I would solidify a discipline that caters to this and allows everybody to understand what we're talking about, and allows everyone to feel that they're part of this way forward to bridge inequities and disparities.
But I think that you've got a great conceptual framework for equity medicine, equity neuroscience. And I think the thing that you really keep stressing is that it's a team effort. This is not one discipline water to carry singularly. It is a team effort. And I think that the concept of brain health, which the American Academy of Neurology has over the last 2 years really leaned into and is taking the lead on refining the concept across the lifespan, and that healthcare equity is a critical part of that, in that if we can solve these problems, figure out ways of addressing inequity, it's going to contribute to our overall knowledge on what's best for brain health, and brain health being best care and optimization of brain function across the lifetime, hopefully to at the very least delay neurological disease, if not prevent neurological disease. So you've got, I think your direction is, you're leading us to a destination that I think everyone should be able to get behind. So there is a question here in the chat. We're going to open it up to our audience now. And I'll start with the chat question. And then we can have people, if they would like to ask a question themselves, then we can field those questions. Here we have from Ms. Berger, the issue with underserved populations is that this population is not in the habit of seeking lifelong medical care and health awareness. Often they do not have yearly medical appointments that could often avoid various disorders. So it would seem that there is a great need for training about healthcare in the underserved populations so that there begins an increase of seeking medical care in their lives. How would you suggest that kind of education take place?
No, it's a great question, and thank you for the question. I think that the question, obviously, again, to what we've discussed earlier, lots of people need to be educated. And I think that education needs to start from medical school and find its way all the way through residency and fellowship, and also be part of continuing neurological education, so to speak. Now, the premise, of course, there is absolutely correct, that many underserved populations typically, for a variety of reasons, many times it's means, but of course, many times it's also trust as well. They do not seek appointments or take medications the way they should. I was disheartened to see a study last year. It was part of the Get With the Guidelines stroke registry, which analyzed reasons for factors that contributed to declining intravenous tissue plasminogen activator, TPA, clot busting medication, which has been shown to improve outcomes when somebody has a stroke. And a significant and independent predictor of declining the medication was being African American. And it makes you, so we talk about not having access to the treatment, but we now talk about having access to the treatment, but then refusing the treatment. And what are the factors there? The factors there could be trust. The factors there could be insufficient awareness about the benefits. But again, that's what has to go into the education of providers, of trainees in medicine, so that they realize that certain populations either don't have the means or have barriers that need to be overcome. Cultural sensitivity is extremely important in terms of being aware of the patients that you serve. When we did it, we were part of a survey that was done by the Prime group of stroke patients and their providers. And it was interesting when they asked many of the same questions to non-Hispanic white stroke patients, minority patients, largely African American and Hispanic, and then the providers themselves, how there were different responses to the same questions. But the minority patients many times spoke about the issues of the social determinants of health, many times spoke to the issue of trust, while the responses from the non-Hispanic white patients were very, very different. And then the providers, people like myself, were completely not aligned with the issues that seem to be most important to these minority patients. So clearly a disconnect there that can only be bridged by better education, better training of providers so that we can actually meet the patients where they are if we're to have any chance of bridging those outcomes. For a long time in medicine, I was very focused on the latest and the greatest and the therapies, only to realize, only to be humbled that many times that my patients were not able to comply. At UCLA, where Charles and I practiced, it was very different. I would come in and speak to my patients about eating fish 3 times a week and how it prevents stroke, exercising for more than 20 minutes, 4 times a week at least. Many of my patients couldn't afford to do all the things that I was doing, either because their neighborhoods were not safe, either because they didn't have the means to go to the gym. And so again, it's that kind of education that's important. You have the evidence in front of you, but it's how you allow that evidence to actually translate to benefit for the patients. And I think that's where education is extremely important. Thank you.
Yes. And I remember a stroke patient that I believe you saw as well, that we both took care of, who we talked about diet, and he was in a food desert, and a plant-based diet, or low cholesterol, eliminate fried foods. Getting to some place to buy that food was a monumental hurdle. Not to mention the cost,
Exactly.
where the junk food is cheaper and provides empty calories. It's daunting at the provider level to deal with this, but the meaning of the term doctor is teacher, and so you're speaking to teaching being the teachers to our patients to raise that level of awareness.
And so no, and I remember that, Charles, and thank you for bringing that up. And that's why even for me, a couple of years ago, I started to have these kind of conversations as part of my encounters with patients. And again, it's not because I know it all or I know how to get them the resources, but I realized that it was imperative if I was to have any chance in helping them to comply with some of these evidence-based recommendations. So routinely, I would ask some questions about such things, about the issue of food deserts, and where there are situations where I can get a social worker to help or a case manager to help, I will. And when I follow up to see the patient, I check as well. Again, the issue is not so much being the expert or knowing how to solve it, but it's more recognizing that this is part of the plan, the therapeutic plan that you should be thinking about. And to every extent that you can make referrals or teach, you should do so. I think, again, we are not always taught to do that routinely, and especially also because there are also time constraints as well. But increasingly one finds, especially for underserved populations, this is extremely important.
I'm not seeing another question in the chat, but I'm going to let's see, maybe one came up here. Oh, here we go. This is from Shanicia H. Do you feel the lack of pursuit for long-term health care by underserved populations has an effect on or creates a false narrative in neurological research?
Well, I mean, I think it's a great question. I think it still goes back to the issue of what's causing the lack of pursuit, right? Is it means? Is it trust? Whatever the reason is, the answer is inherent in your question. Yes, it is. I mean, the inability for underserved populations to engage in long-term care certainly worsens their outcomes and causes us sometimes to look for reasons that are biological, but are really not biological, right? It causes us sometimes to feel, okay, well, and this is one of the other things I was alluding to earlier, which is the issue of health disparities and always studying the problem rather than seeking ways to intervene, because it's important to study the problem, but when a population constantly hears how, unfavorably they compare to another population again and again and again, it fosters a sense of resignation rather than a sense of, we can do this, or there are factors beyond our control that might be addressed. And I think that's extremely important. And so, yes, there are clearly differences when it comes to chronic care by race and ethnicity, and they certainly play into the outcomes that minority and underserved groups experience. And they sometimes lead us to perceptions and investigations that may not necessarily be warranted if we address the issue of trust or we address the issue of the social determinants.
Okay. Marcus Wolf asks, how important are collaborations with policymakers?
Crucial. That's a great question. One of the examples I should give is the example from our Cyrene study in Africa. So Cyrene, I didn't mention the name Cyrene, but I had alluded to it earlier, which is this very big stroke study that we had in Nigeria and Ghana, 15 different sites. And one of my proudest moments was when we passed the first ever stroke prevention and control law in Nigeria on the basis of the findings from Cyrene. And the reason for that was from the get-go, we involved policymakers and public health officials in the study. So we created these community advisory boards. And so they knew what the study was about. They met on a monthly basis and were apprised of how the study was going. We invited their input and everything. Once the findings came out and they were ready, it was so much easier for us to now go to the legislature and talk about passing this law, because we had two legislators who are part of our community advisory board. And I think it's extremely important to do that. So, and I'm a big advocate, not just for doing that for research when you're having a study, but, and I've said it in other fora, I think it's important for departments of neurology to routinely have a standing community advisory board, a relationship with stakeholders in the community, especially if you're serving a vulnerable and underserved community. And many of our top-notch institutions and departments tend to be located in areas where there are a lot of disparities. And so having that kind of community advisory board where you have people, representatives from the department, but also representatives in the community, policymakers at different levels, but also people who are leaders in the communities, whether it is pastors or imams or other types of community leaders, is extremely important. Important in terms of not just passing policy or passing legislation, but in terms of recruiting. Many times people have difficulty recruiting underserved patients into their trials. Having that kind of relationship and understanding, and not one in which it is, the ivory tower speaking down to the community, but a community, a relationship or relationships that are built on respect and ability to allow the knowledge and wisdom from the community also to be shared with those in the ivory tower, I think would be very important.
No, the coming down from the tower or opening the door to the tower is going to be a critical part of the solutions, because that's where going from just studying to actually doing will really take hold. And there'll be an accountability factor there if you have the voice of the community and the policymakers. So yeah, I fully agree with that assessment. Question from Rodney Laycock. How do we build safe and trustworthy places for underserved communities to receive neurological care?
Dr. Leacock, it's great to see you on. Thanks for that question. And I'm sure you can also speak to that as well. But no, I think education is a start, and this has been asked, and Charles and I have spoken about this. I think organizations, and by organizations, I'm not talking about leadership and the institution itself, but also individual providers, all I think need to expose themselves to cultural sensitivity training, not on a one-time basis, but on a routine basis, and maybe have a sense of more humility towards addressing vulnerable and underserved communities. I think because of history, I think that's not something that will happen overnight. But I do think that with education and with accountability, one can begin to make solid steps in the direction of trying to assure safety and trustworthiness for our vulnerable and underserved communities. I know that here in the Bay Area, certain healthcare systems have trust clinics where they have racially and ethnically concordant providers providing care to vulnerable and underserved communities. And in such clinics, while they strive for race concordance where that's possible, just because there have been several studies showing that race concordance where the provider and the patient have similarities. Sometimes this can be similarities in terms of gender, sometimes similarities in terms of race or ethnicity, sometimes similarities in terms of age, that there's much greater trust when that occurs. But in these trust clinics, they also have majority providers, so to speak, but these are majority providers who are also culturally trained in cultural sensitivity as well. And so it's having these oases, so to speak, these clinics. Now, we can't do that everywhere all the time. It's impossible. But it is an avenue to begin, especially for organizations that may not necessarily have as cordial a relationship with their neighboring communities as they could. Having such trust clinics can begin that conversation and show good faith efforts in trying to build and nurture those relationships. Again, I don't expect that will happen overnight, but that will be some of the type of things that I think would be important to do.
Yeah, I think examining the structure of clinics and having those additional skill sets on communications will be important going forward. It's just, getting that, and that sort of goes under the tent that I'm currently sort of tending, which is continuing professional development, of getting education out to providers in the workforce now to skill build. And that's something that at the Society for Academic CME meeting a couple of weeks ago, this was actually a part of the main theme of the conference. So in the continuing medical education world, we're starting to address this gap in knowledge that exists.
No, Charles, and I think that's extremely important. I mean, I think there are two issues here, right? One is the issue of the education, but the other issue is the getting people to be interested and volunteer to expose themselves to such
Yes.
education. And I think that those two things are important, because what we have found many times is that the people who expose themselves to such education already had a huge interest in it, in doing that already. But there's a broad proportion of folks that one would like to encourage to see that such training and such education is extremely important to achieve what you had just mentioned, which is brain health equity for all. Yep.
Yeah. So just to get into controversy, you know that there was a California Medical Board stipulated a DEI requirement for CME. And I think that is currently in the courts. There's someone filed a suit. So this was an effort to sort of nudge people into taking part in this type of education. Do you think that's the way to do it, or is it a matter of taking a more Madison Avenue approach and to entice people to add these skills?
Yeah, no, I don't know what. Of course, it's I don't know the right answer to that, but I I think people, of course, who are in our field want to make a difference, want to make people feel better, want to save lives. And to me, more than any other field, that's a wonderful, wonderful thing to know. But I think it's up to us, folks in positions like yours, Charles, um, to alter the narrative, so to speak, to allow people to feel, we speak about belonging, people to feel that this aligns with the Hippocratic Oath. This aligns, with what they have set out to do with their lives professionally. And many times I get the sense that not everybody sees it that way, right? And I think part of what we have to do is to make that, because the alignment is there. It's just that there are other things that sometimes get in the way. And so that would be my 2 cents on that one. But that's a tough one. It's a tough one.
Yeah, I think that your equity neuroscience concept it appeals to academicians. It's the community, it's out in the community where I think there has to be a variation on that
Right.
messaging.
Right.
But I also agree with you that our colleagues are all on board with making people better, improving people's lives. And so starting from there is a lot easier.
Yes.
If that's your floor.
Yes.
Yeah. Let's see. We have, I think, well, I think we're about to running up on time. I'm getting the shepherd's crook here. So really, Bruce, it's been a pleasure.
Pleasure and privilege all mine, Charles. Thank you so much. Thank you, everyone.
As always, when I have a conversation with you, I learn. So I'm always indebted to you from that perspective. Before we say goodbye tonight, I want to thank everyone in the audience for joining us. And again, thanking Dr. Ovbiagele for giving his time and sharing all the wonderful work that he's doing and giving us a vision to the future. And that hopefully there's been some seeds of inspiration planted here and that we will see the fruit of that in the not too distant future. The ABF hosts free webinars regularly, and we'd love to see those of you who attended tonight again. The next event will be on May 21st on maximizing quality of life at the end of life with Dr. Maisha Robinson. You can also follow the American Brain Foundation on social media to stay up to date on brain disease information and research. I invite you also to listen and visit the Brain and Life website and listen to the Brain and Life podcast. Brain and Life is the official publication of the American Brain Foundation's partner organization, the American Academy of Neurology, with information and resources to help you keep your brain healthy. You can also support innovative research to find the cures of tomorrow by making a donation to the American Brain Foundation. And you see here the QR code and the web address. No donation is too small, and all are deeply appreciated. The American Brain Foundation cannot do this work without your support. And on that note, again, thank you, Dr. Ovbiagele. Thank you to the American Brain Foundation. Look forward to celebrating Dr. Ovbiagele and the other honorees at the gala next month. And to everyone in our audience, thank you and good night.
Good night. Thank you, everyone. Thank you, Charles. Thank you, ABF. Thank you.